Hello, everyone. Good evening to everyone in India and good afternoon to everyone in the UK. Welcome to the South Asian Health Foundation's fourth webinar talking about COVID. These are clinical knowledge exchanges between experts in India and the UK. My name is Rachna Chawla. I'm a GP and one of the joint directors of clinical strategy at King's Health Partners. Today's topic is prevention, diagnosis, and early management. And the purpose of today is really to share the learning that we have had here and the learning that's happening at the moment in India. We've got some amazing experts in their field. We will have to start off with, to help set the current context in India and home-based care, Professor Prabhakar Doriraj, who's a Vice President of Research and Policy and a Director at the Centre for Control of Chronic Conditions at the Public Health Foundation of India. We will then have Professor Jaydeep Menon joining us. He's a preventative cardiologist and Head of Population Health Sciences at the Amrita Institute of Medical Science in Kochi, Kerala. He'll be talking about the diagnosis of COVID and the change in the symptoms between the two waves, and a little bit on vaccines. And then our third speaker today will be Professor Trish Greenhalgh, who is a Professor of Primary Care Health Sciences at the University of Oxford. Trish will be talking about prevention in the context, Trish will be talking about prevention and preventing the spread of COVID-19 and asking what are the most effective strategies. And then last but not least, we've got Professor Kamlesh Kunti, who's a professor from the University of Leicester. He's a professor of primary care, diabetes and vascular medicine, and he'll be talking about prevention in the context of multi-generational households. We will have time for Q&A later, but please pop your questions into the chat and our panelists will try and answer them as we go along. I'm afraid we're unable to talk about individual cases with regards to those questions. Just a couple of housekeeping things. If you're please able to keep your cameras off and keep yourselves muted. The slides and the certificates will be made available on the SAHF's website afterwards, as well as the video. And like I said, we'll be happy to answer your questions, so please do put them in the chat. So with that, if I could please invite Professor Prabhakar to show your video and unmute, and thank you very much.
Right. Thank you, Dr. Chawla, for that very kind introduction, and thank you to SAHF for inviting me to give this talk. I'm really honored to be here. I'm going to address only two questions. I'm going to briefly talk about the current context of COVID-19 in India, and a concept that we have developed on home-based care, and I'll present some of the details to that. Can I go to the next slide, please? So we all know that India successfully navigated the first wave through a series of measures that included total lockdown initially, followed by a calibrated lockdown and what they called as unlock over a period of time. And that success kind of lulled the country into great confidence, and we prematurely started opening up. Despite some warnings in terms of the second wave coming up and some examples from other countries, there has been a second surge from the month of February onwards due to a variety of reasons. I mean, we have had large crowd gatherings, we had religious gatherings, political gatherings, so on and so forth. But in addition, I think one of the things that really tripped the whole thing was the occurrence of new variants, particularly the ones called B1.6.17 and B1.618, which are homegrown mutations within India, and some which came from UK actually, which is the B117 through travelers. Now, what has happened is that all these mutants resulted in a rapid spread and a rampant spread of COVID-19 across the vast swathes of India. So much so, in the end of January, early February, the whole of India, the R0, which actually gives the reproductive value, was close to 1 in most parts of India. In fact, in some places it was less than 1. But now it's become more than one in most of the places, and in some places like UP, Bihar, etc., it's estimated to be close to 3. The other feature of this surge has been rapid spread into rural areas in many parts of the country. And at the highest so far, we have had more than 400,000 patients on a single day. That was around 10 days back. Next slide, please. The other feature is, unlike the first wave, a large number of young people have been affected, and some of them have lost their lives too tragically. There's high levels of infectivity and high positivity rate. One might say the testing is lower, and because of that, positivity is high. But with the same amounts of testing, the positivity is coming down wherever the COVID-19 peaked. The positivity at some points of time have been close to 60-65%, which means for every 100 people tested, 65 are turning out to be positive. That's phenomenally high. Now, the rapidity with which the disease occurred led to overwhelming of the health systems. But as you know, in India, there's a great degree of heterogeneity in the healthcare. So states with good primary healthcare system and health management information system perform better. Like states like Kerala and Tamil Nadu have not seen the kind of problems that have occurred in many other parts of India. A lot of remedial measures have been put into place. Some hospitals have come up very rapidly. There has been global support, including the import of oxygenators, pulse oximeters, drugs, and several others, and that has really helped. The other thing is treatment protocols have undergone some change, but still most of the protocols in the country suggest that ivermectin should be given for at least 5 days. And many protocols suggest that the budesonide inhaler of 800 microgram given twice a day for at least 5 days for milder cases would be useful. It appears that COVID-19 has peaked in big cities, but the status in rural areas are still very, very unclear because of the lag in reporting and several other infrastructural issues. Next slide, please. So given that there is such an overwhelming of the health systems and the non-availability of beds and ICU beds, etc., I think we need to relieve the pressure on the public and private healthcare systems. So it's important to triage COVID-19 cases and discourage hospital visits for those that do not require hospital-based care. And triaging for home-based solutions should ideally be done from the patient's home itself. It's also important to ensure that quality healthcare is made available at home through appropriate use of digital health technology. And we at the Public Health Foundation of India, with our experience in a telemedicine program that we are conducting in Chennai, have actually developed a process of symptom-based triaging adapted from the Ministry of Health and Family Welfare, All India Institute of Medical Sciences, Indian Council of Medical Research for self or assisted assessment. And we also created a modified doctors interface to provide access to patient CHR, current COVID-19 triage status, as well as longitudinal data to assess improvement in vital parameters. This will be rolled out soon. Next slide, please. So just to give an example of how it works, for mild cases, the patient is triaged with mild disease. The call would be transferred to a physician for teleconsultation, and an e-prescription will be issued, and a repeat triage, if required, can be conducted every 3 days. Next slide, please. In terms of moderate cases, the patient will be triaged and the call transferred to physician for teleconsultation. Then the call would be transferred to a healthcare worker for a house visit appointment. And the healthcare worker should be ideally provided with a care kit, which includes a pulse oximeter, a blood pressure apparatus, the sanitizers, some drugs, and so on. And an e-prescription would be issued. The hospital visit, caregiver training, parental medication, and baseline blood samples would be conducted. Follow-up visit would be on the 3rd or 5th day. And again, an evaluation, teleconsultation, and e-prescription would be done. So if the person is stable and can be measured measured through the telemedicine, patients could be discharged and the care kit recovery initiated and sanitized. at the telemedicine center. Next. For severe disease, obviously, the patient has to be referred to a state helpline, and nearest health facility should be identified and an arrangement for ambulance services provided. Next slide, please. So this basically comes from our experience of the PHFI telemedicine platform, which I'll explain in very brief. Next slide. So the whole idea started that we need upscaling of skills of the health workers in providing assisted telemedicine. This would improve access to primary and tertiary care through trained personnel, improving quality of care through point-of-care diagnostics and electronic clinical decision support system, and reducing the need for follow-up visits to health facilities and real-time monitoring and feedback mechanisms that assure quality standards. So this was our original intent. I think this is going beyond the COVID, even for the COVID surge now, look at the third wave before it comes, but also in the long run, to avoid patients coming to the hospital, we have created this. Next. So the telemedicine platform of the PHFI embeds electronic health records, point-of-care diagnostics, electronic clinical decision support systems, and numerous state-of-art digital health technologies, which I'll show in the next slide, please. So we have created an electronic clinical decision support system, essentially for the management of hypertension, diabetes, coronary artery disease, chronic obstructive lung disease, and several others. In the back end, we have put in around 3,000 case studies, and we have created an AI-based system which can give personalized diagnosis as well as management plan. And this can be run in tandem with a physician prescribing remotely, but history and physical examination being conducted by a nurse. In addition, we have a point-of-care device which can conduct at least 11 tests, and we are upgrading it to have even more tests. A small handheld ECG machine is also paired with the telemedicine device, and we have wanted to give eyes and ears to the doctors who are remotely situated. So we have paired them with a steth and a very high definition camera. Next slide, please. So this is the portal. I wouldn't get into the details. It's a very, very simple portal which has a patient interface, a healthcare worker interface, as well as a doctor interface. Next slide. So this is all I wanted to say. And essentially, the whole idea was using the telemedicine platform that we have developed, and we are using it in Chennai. We wanted to create something where we can triage patients and reduce their hospital visits unnecessarily so that we can relieve the pressure on the hospitals. I'll come back for questions. Thank you very much for listening to me.
Thank you so much, Prabhakar. Thank you for painting a picture of what's happening and the initiatives that you're involved in. And over to you, Jaydeep. Thank you.
Thanks, Dr. Rachna, and thank you, SCHF, for having me here. Lovely talk, Dr. Prabhakar, as usual. What I'll be speaking about is the COVID-19 symptoms and diagnosis and the differences therein between the two waves of the pandemic. What is the difference in either the host, the agent, or the environment that is actually triggered of the second wave? Next slide, please. Earlier, it was thought that coronaviruses are restricted to species, either animals or humans. Turn of the century, 3 coronaviruses have actually breached this species barrier, having led to pandemics. These zoonotic pathogens belong to the beta coronavirus genus, 4 of which are known to be endemic in humans, as also the SARS-CoV-2 binds to the ACE2 receptors and which serves as an entry site or entry receptor for invading target cells. Next slide, please. Coming to the 3 pandemics, between 2001 and 2003, severe acute respiratory syndrome coronavirus infected about 8,000 people with a fatality rate of 10%. MERS infected 1,700 people with a fatality rate of 36%. And since 2013, porcine epidemic diarrhea coronavirus spread across the US, causing an almost 100% fatality rate in piglets and wiping out more than 10% of the American pig population in less than a year. Next slide, please. So a few words on the host factors. ACE2 is a zinc-containing metalloprotein enzyme richly present in the type 2 alveolar cells of the lungs, enterocytes, endothelial cells of the arteries and veins, and also certain parts of the brain. This is the portal of binding of the S protein of the SARS-CoV-2, which further undergoes activation and which serves for invasion of the target cell. Next slide, please. So what are the tests that are routinely done for the diagnosis along with the clinical symptoms? The usual tests done are the antigen antibody or the PCR or the polymerase chain reaction. The RT-PCR or the real-time PCR is the gold standard from amongst these tests. The disadvantage to this test being a run-in time of 6 hours, the advantage being that 96 tests could be done in a single cycle. The Express SARS-CoV-2 is actually it's the MDR, it's the test that was made for the diagnosis of MDR tuberculosis. And this has been repurposed for the diagnosis of SARS-CoV-2. The advantage is it's got a run-in time of 45 minutes only, whereas the disadvantage being only 4 test cycles could be done at a time, just like with the TrueNat. The antibody test, which has a run-in period of only 30 minutes, is more used for for surveillance rather than for diagnosis. Next slide, please. Now, the symptoms that an individual usually presents with are similar to any upper respiratory viral disease, but some patients take a turn for the worse, leading to multi-system failure as well. Thankfully, 80% of patients have mild or no symptoms at all. Less common symptoms include ageusia, anosmia, headache, etc. Next slide, please. Now, the organs involved depend more on the density of the ACE2 receptors in them. The primary organ involved is the lungs, the type 2 alveolar cells being involved. It may range from an upper respiratory illness presenting as dry cough to a pneumonia affecting both lobes, an acute respiratory distress syndrome, or even pulmonary infarction for that matter. In the kidneys, hematuria is most common alongside proteinuria and acute kidney injury. In the heart, it can range from myocarditis. Certain people come with symptoms suggestive of a stress cardiomyopathy as a sentinel event. In the gastrointestinal tract, with involvement of the enterocytes and cholangiocytes, the common symptoms being anorexia, abdominal pain, and diarrhea. Psychiatric manifestations are known. Next slide, please. So for the clinical classification of severity, SpO2, respiration rate, chest X-ray, CT scan, and the symptoms are taken for this clinical classification. Next slide. For the laboratory classification, the neutrophil lymphocyte ratio, the C-reactive protein, ferritin levels, D-dimer, lactate dehydrogenase, interleukin-6 levels, and the transaminases are what decide severity. Next slide, please. The previous slide, please. The cycle thresholds required for a RT-PCR, if between 17 and 24, would suggest a very high viral load, which could lead on to severe illness. Similarly, CT is a good tool for grading of disease. The 5 lobes of the lung are graded between 0 and 5, 0 with no involvement at all, and 5 with involvement of more than 75% of the lobe. So of a max of 25, if the score is above 15, it would convey a bad prognosis. Next slide, please. The clinical red flag symptoms include a high pulse rate of more than 125, a respiratory rate of more than 24, low blood pressures, altered sensorium, and low SpO2 on room air. Next slide, please. Alongside the other parameters that I just mentioned, elevated NAT-pro-BNP levels, along with troponin elevations, also carry a bad prognosis. Next slide, please. So this is a slide which gives us an idea of how the patients actually behave and present. 80% of them tend to be asymptomatic or mildly symptomatic and would require just home quarantine. Out of the rest 15% would have mild to moderate symptoms of either a upper or lower respiratory tract involvement, which would need care in the first line COVID care center. Whereas out of the 5%, it's only 1% who take a turn for the worse, end up on a ventilator with invasive ventilation. And unfortunately, a good number of them don't make it. Next slide, please. Now, shifting gears, seroprevalence studies detected the presence of antibodies in 20 to 30% of the overall population in India, starting end of November and December. And this was as high as 50 to 60% in crowded areas of Delhi and Bombay. Next slide, please. Now, what has powered or triggered off the second wave, as Dr. Prabhakar mentioned, is the so-called double mutant, which which was first reported in India in December, which alongside the introduction of the UK variant in January 21, is what has powered the second wave in India. This so-called double mutant has 15 changes from the original, 6 mutations of which are in the spike protein, and 2 of these are in a critical region called the receptor binding motif, which is where the antibodies might bind, and mutations here may actually, next slide please, may actually help the virus evade antibodies. So of the 2 key mutations reported, one was first reported from a mink population in Denmark, and which was later responsible for the outbreak in Southern California. The second mutation is very much identical to the South African variant, and this is thought to be responsible for partially evading antibodies. These 2 mutations came together for the first time as we know it in this Indian variant, and this has since spread to 44 other countries of the globe. Next slide, please. So 80% of the viruses circulating in Punjab and Haryana is the UK variant, whereas in Delhi, it's a mix of both the UK variant and the double mutants. In Maharashtra, roughly 35 to 60% is actually the double mutant. Now, coming to the symptom complexes, the symptomatology differences between the first and second waves. In the first wave, the typical symptoms were more common, like dry cough, joint pain, and headache. In the second, shortness of breath was reported in 41.7% in the first and 47.5% in the second. Oxygen use was much more in the second wave. Mechanical ventilation was also significantly more in the second wave. Next slide, please. Importantly, symptoms of diarrhea and abdominal discomfort are more seen with the second wave and are seen to be more common in the prior vaccinated. This alongside conjunctivitis and a sore throat. Sore throats were also less common in the first wave, whereas sore throats are much more common in the second wave. Also, transmissibility of the virus is also much more in the second wave, in the sense that every family member of a household tends to be affected during the second wave. Also, we are seeing more and more cases of the black fungus or mucomycosis, which may be resultant from the treatment that we're giving. Thank you for your patient listening. I'll be happy to answer questions at the end. Thank you all.
Thank you so much, Jaydeep. Thank you. If I could please ask Trish to come on screen. Thank you.
Hi, thanks very much, Rachna. So I've been asked to talk about prevention, remote triage and monitoring. I'm going to spend most of my time, I think, on the first of these. Next slide, please. So yeah, I'd just like to thank some colleagues for these lovely pictures, which I'm going to be talking about. Next slide, please. So prevention, next slide, please. Now, many of you are going to know quite a bit about prevention already. You know about the slogan, hands, face, space, ventilate. The face there stands for masks, obviously. And you may well have heard the 3 C's recommendation, which originated in Japan: avoid crowds, avoid closed spaces, in other words, indoors, and avoid close contact. Now, those messages can be packaged in many different ways. And I suppose the one thing I wanted to get across with this slide is that the prevention messages really need to be very simple. They need to be culturally congruent and available in all the languages spoken locally. So posters and pictures and messages which are made locally and distributed locally are often particularly effective, and there's quite a bit of kind of communication psychology evidence on this. This is from Dharma Life, which is one of your Indian artwork websites. They've got some fantastic resources, not just around COVID, so give them a plug. Next slide, please. I now want to just talk a little bit about ventilation. My team have recently published a paper in The Lancet summarizing the evidence that this virus is spread through the air. There isn't really any scientific doubt about that, and the implications for prevention are these, very briefly. Firstly, that outside is safest. The safest way to reduce transmission is for everyone to be outside so that virus can float away in the air. Wherever possible, your screening, your assessment of patients should take place outside. People should wait outside. And as illustrated here. If you're using a marquee or a tent or something, leave the sides open. Next slide, please. Next basic message, open the windows. I'm sure you know this by now, but this room really beautifully illustrates the importance of opening more than one window. Have the door open if you can, because then that gets a through draft. You want that breeze to be going through the room. Next slide, please. Avoid overcrowding. I'm sure we've all seen a hospital waiting room like this. The more people in the room, the higher the risk. So if we have to wait indoors, make sure everyone is wearing a mask and that it is well fitting, but preferably get people to wait outside for as long as possible. Next slide, please. Here's an interesting tip. Set the extractor fans to blow outwards. So in any room with the patients, it needs to pull that air outwards, not inwards, and leave it switched on at all times. You can actually just hold a piece of tissue over the fan to see which direction the air is flowing. Next slide, please. Unblock the air vents. There's been some unofficial research in some hospitals, and they've found that a lot of these air vents have been blocked off, particularly if there's air conditioning. So make sure that there's no tape over these so that they can actually work. Next slide, please. So here is a picture of our COVID risk chart. You can't see the detail here, but what we've done is we've looked at different scenarios. You can see these in various different Indian languages. We have them in more than 50 languages, so just ask for them. We're looking at different scenarios here, whether people are wearing a mask, whether they're not wearing a mask, whether they are in the room for a short or a long period of time, and also what they're doing in the room, whether they're staying quiet, whether they're speaking, or whether they're shouting or singing. You will probably know that singing indoors is a particularly high-risk activity. The red areas are the places where you're most likely to get COVID. So if people are indoors with poor ventilation and singing away. So do ask the South Asian Health Foundation if you'd like copies of those. You can use them and reproduce them. If you'd like to translate them into different languages, we can give you the source documents. Next slide, please. Quick on remote triage. So this is more than a year old, this paper in the British Medical Journal now. We developed a very brief remote assessment guide for use in primary care, and you've already had from Professor Prabhak the Indian version of it, which I think is rather better. This was done very quickly at the beginning of the pandemic. Next slide, please. So we didn't really know in March 2020 what the key signs of deterioration were. So we had our red flag signs. I think that they haven't changed all that much, but as you've heard, there's been a few changes. Next slide, please. But what I did want to highlight from that paper is, what do you do to assess someone's breathlessness? This is something that I've been very interested in. I've been doing some research into. And the bottom line here is that qualitative questions seem to be more sensitive and more specific than quantitative scores. In other words, what you want to try and get from your patient is a story about what is happening, how badly they're affected, and particularly how quickly it's getting worse. The trajectory of breathing is very important. What can't you do today that you could do yesterday? Those kind of questions. So although we're all busy, you've got a lot of patients to listen to, make sure you take a history of the trajectory of breathlessness. Next slide, please. These questions have been translated to Hindi already. If anyone wants to translate them into other languages, that would be fantastic. Next slide, please. What we've been doing with the assessment of patients with acute COVID, we've developed a score called RECAP, which stands for Remote COVID Assessment in Primary Care. And at the moment, it is based very much on clinical consensus and histories from patients. We've done a couple of hundred of these. I told you about the red flag symptoms. I think you'd know those are straight. We need to send the patient into hospital. And then you can see these 10 different criteria, which depending on the result of them, we score either 0, 1 or 2. And this recap score is now being validated in about 12,000 patients using data linkage. And we're following them up to see which of these early symptoms actually predicts hospital admission, intensive care unit admission, and death. So we should have those results. We're working really hard to get that score because we know that many countries, including India, would like a validated assessment score. We should have those results by next couple of weeks. Next slide, please. So just a little tiny thing on monitoring, and this is really my last slide, so I don't want to go over time, which is what do you do when you're monitoring a patient and you don't have an oximeter reading? I know some patients have got oximeters, but most do not. Even if they've got one, it may not work particularly well, it may not be quality assessed, or the patient may not know how to use it. So what we've been testing, and I can't give you the results yet, is whether or not the symptom of shortness of breath, measuring the respiratory rate, looking at the rapidity of the trajectory of breathlessness will substitute for that oximeter reading, which is what you really want. And one of the things we're testing for that is the profound tiredness or fatigue, as to whether the patient, if that symptom of fatigue, which as you know is very, very common, can be used as a kind of substitute for the oximeter reading if we don't have that. So watch this space for results. I'm sure we'll post them on the South Asian Health Foundation website when we've got them. So I think that's my last slide. Just thank you again for your attention, and I'll hand back to Rachna.
Thanks so much, Trish. And we have our last speaker, so Professor Kamlesh Kunti, who's going to talk about prevention in the context of multi-generational households. Thank you very much.
Thanks very much, Rachna. Thank you all for joining. Next slide, please. So the reason we're talking about this is because we've had a great interest in ethnic minority populations. We were the first ones in the UK, I think, to alert the world that ethnic minorities are disproportionately affected. This is data we did very early on, 61 million people database, showing that Asians and Black communities were affected 40% to 70% at a greater risk of mortality. And so some of the factors that we see in our ethnic minority population, Asians, may be similar to what we have seen in the Indian diaspora. Next slide, please. The reasons for increased risk in ethnic minority are complex. It could be differential exposure, differential vulnerability, different disease consequences, different social consequences, different effectiveness of control measures, and different consequences of control measures. And some of these you've been hearing about today and in previous presentations as well. But we'll concentrate more on the differences in the vulnerability today. Next slide, please. So what we found from the UK is basically there are a number of factors that are associated with worse effect on ethnic minority, particularly South Asian populations. And these are multi-generational households. As you can see here, Indians, Pakistanis, and Bangladeshis are more likely to live in a household where there are 3 generations of families. And this is typically what we would see in many rural areas in India and some cities as well. Next slide, please. And this is showing again the context of how the last 3 bars, how many individuals live in a family in terms of generations. So what we see is there are more people with 3 generations living in a family in the Indian context than in other ethnic groups. And this is an important factor. Next slide, please. And the reason it's an important factor is the other key factors associated with getting COVID and severe COVID are key worker status. So people who going out to job and contacting lots of people. Deprivation, which is rampant, obviously, in India. House density, small housing, a lot more people, small room with lots more people living in there. That's a likelihood of spread, as Trish has mentioned, and multi-generational households. And particularly multi-generational elderly members or middle-aged members who have other risk factors such as diabetes, cardiovascular disease, chronic diseases. And next slide, please. So the scenario that we've looked at, and this is again looking at data for the whole of England we've modeled, is that you will have age, ethnicity, underlying health conditions playing a part. But household composition is all really important. Overcrowding in multi-generational households will then lead to increased susceptibility and increased risk factors for COVID, getting COVID and consequences of COVID. So the scenario we're seeing in the UK is that a lot of the Asians have key worker roles, either working in the healthcare setting or in patient-facing or public-facing roles. They get the disease, they get mild illness, sometimes asymptomatic. They come to the house, it's passed on to the elderly population in the house who get the severe consequences. And that's the chain that we really want to stop. Next slide, please. One thing that has worked around the world, including the UK, and I think UK, again, we looked at this using the large UK database of 61 million people, is that lockdowns work. Lockdowns work in every community. If you have a good quality lockdown, as you can see here, in the greens pre-lockdown, in the yellow post-lockdown, lockdown has worked in nearly every ethnic minority groups. Next slide, please. And these are simple measures. Trish has just gone through some of the simple measures that you can implement in multi-generational households. And these are, again, simple measures that you could take forward. These are all available, and we've got these. Next slide, please. We've got these in 5 languages. These are all downloadable from the South Asian Health website. These are simple messaging to populations of different minority groups and different South Asian groups. So please do use them. Next slide, please. So really, we're looking at simple strategies, looking at making sure that the communication is getting to the public out there in different format, different languages. WhatsApp seems to be the way to get messages to the masses in India, but there are many people who want to have access to that. Short videos seem to be working in the UK. These are kind of the modalities that we're using. Messaging regarding occupational risk, people who work in certain work conditions, and them coming back to the house to ensure that they've had a good hygiene, had a clean up as soon as they come to the house, trying to social distance as much as possible. Ventilation we've talked about. Really important to measure risk factor control. I'm not going to go into this, but blood pressure control, a high HbA1c in people with diabetes, all of these are associated with worst outcomes in people who get COVID. Improving vaccination, I know it's easily said than done with the difficulties you're seeing in India. And there may be other strategies that we can't think of, but you may have local strategies which may have direct or indirect impact. One of the things we've talked about and families have done in the UK is if there were families who had a key worker and the parents were living with them, they've moved them to another brother or sister where they didn't have children or they didn't have key workers within that house, just to try and reduce that risk. So these are simple strategies that could be implemented if possible at all. Next slide, please. I think that's my final slide. Thank you very much for listening.
Thank you so much, Kamlesh. I'll ask you just to stay there and invite the other panelists to also appear on screen. And I'd like to introduce Dr. Alison Tavare, who's a GP and also clinical lead for COVID oximetry at home in the west of England, who's going to help facilitate the Q&A. Thank you so much, Alison.
Thanks very much, Rachna. And thank you also to the speakers, because when Rachna started, she said it was a knowledge exchange between experts in India and the UK. And I've certainly made lots of notes because I've learned loads from our colleagues in India. So thank you very much. I've also been looking at the questions which have come into various various channels. So we've tried to answer some in the chats, but ones that have been highlighted, and one of them to Professor Prabhakar. One of the questions is, what are the challenges in delivering teleconsultation?
Right. This is actually a work in progress. One of the biggest challenges is education. So that's why you require assisted teleconsultation. Education in the sense not literacy, but in terms of using gadgets, because that's where many people fail. So you really require assisted teleconsultations. And that's where our community health workers are actually helpful in terms of helping people who are not well versed in terms of using smartphones. The other challenge is the non-availability of smartphones with people, because if they don't have a smartphone, obviously they cannot get the teleconsultation. So these are some of the challenges. The third is a language issue. And so we are working on the language issue in terms of using icon-based solutions where people just have to answer plus or minus based on IVRS questions. So that's still a work in progress. But these are the three main challenges that can happen in teleconsultations.
Thanks, Dr. Prabhakar. And one other question, which perhaps, I don't know if you can answer, but somebody's asked how they know that pulse oximeters are of sufficient quality. So in England, we can look for this CE mark, but I don't know if there's a similar kind of trademark or of quality in India, or whether that's something we could find out and perhaps post in after the webinar. Sorry to put you on the spot.
No, I'm not the best person to answer this question. Obviously, there are pulse oximeters with CE marks even available in India. So that's one example. Maybe Dr. Jaideep Menon can answer this question. So there is an organization called CDCSO, which actually qualifies the equipments and devices. So if possibly recognized by them, that could be a good marker. But I will leave it to Dr. Menon to answer this.
Yeah, the same, sir. CE mark holds good in India as well.
Thank
you. What was available in India has also got a CE mark to it.
Thanks very much. Something else that I've learned tonight. I wasn't quite sure. Thank you for that. And thank you, Dr. Prabhakar. So Professor Jaideep, I got a number of questions for you, but one of them was about mucomycosis. And specifically, somebody was asking about the relationship between dexamethasone and the doses of dexamethasone and whether that's linked into mucomycosis. Are you able to give us a little bit more information?
Yeah, definitely there would be a connection between the two. It actually really boils down to as to when the steroids have been started. We know for a fact that in the phase of viremia, that is in the first 1 week of illness, there's no real advantage to giving inhaled steroids or steroid for that matter, unless there is hypoxemia. So what has happened in India of late is, because everyone knows as to what the treatment is, self-medications have been going on at home, either domiciliary or in the first-line treatment centers. And that is probably what has led to this, case reports of mucomycosis. The dose of dexamethasone that is usually given is 6 milligram per day, that is 0.1 to 0.2 milligram per kg per day is the dose recommended. And this is seen more so in diabetic patients and in the elderly and with other immunocompromised states like that, people with renal failure on hemodialysis or chemotherapy for that matter.
Thanks.
Hope that answers the question.
That's really helpful. I think Professor Kamlesh, did I see that you've put your hand up? You had something else to add to that. Thank you.
It was the note that Professor Menon made about other chronic diseases and risk factors. That certainly puts them at a higher risk of mucomycosis. But speaking to the Indian colleagues, I think it's the use of not just steroids, but a combination of antibiotics that's being done in the UK, in India, in mild cases, in the community setting. And apparently this is putting people at risk. And we know there's no evidence base for the antibiotics or steroids in mild disease. And this is something that we've highlighted at previous seminars as well.
Thanks very, very much. And the next question is for Prof. Greenhell. You were asking about symptoms and actually ways of assessing breathlessness. So very much on symptom control, assessing how people are managing if they're unable to measure their oxygen saturations. But we were discussing before we started the importance, if possible, of actually looking at patients and possibly doing video consultations. And I wondered if you could perhaps expand on that and share some examples if you can.
Well, yes. I mean, my team have done an awful lot of research on video consultations during the pandemic, but we have found right around the world that the acute assessment of the patient with possible COVID in a primary care setting very rarely happens by video. And that is partly because of the sheer volume of patients that are often telephoning. It's also about the problem of patients not having the technology or the technology not working. You know, the telephone is a pretty dependable technology. It's quite a widespread technology. It's a familiar technology. Many people know how to use a telephone. And even if there's not one in your house, there might be one in a neighbor's house, et cetera, et cetera. The same is not true of a smartphone. Of course, you know, if you do have one, that's fantastic. But so actually, our data suggests that video assessment is not that common. But if you've got a video connection, if you've got that WhatsApp connection, Skype, whatever it is, then you can make a visual assessment and you can get more information. You can look at the patient, what we call eyeballing the patient. Does the patient look sick or well? If they're a child, are they running around? You know, that kind of thing. You can look at blue lips. So we've had a few people pick up central cyanosis by doing a quick video call. You can sometimes assess the respiratory rate. You say to the patient, put your hand on your chest. Sorry, you can't see my hand on my chest, but they put their hand here and then breathe, and you can see the chest rising and falling. So that's a trick we learned from one doctor who does this. But mostly in the UK, what we're doing now is issuing patients with oximeters and also just going on the history by the telephone, simply because it's in this acute situation, people are not doing it. But Alison, you may have other experience, because I know you've been working in this as well.
I haven't, and that was a slightly loaded question, because as we were saying earlier, that I was speaking to a GP colleague on some work related, on something to do with work, and I suddenly noticed that she got tracheal tug, so she was really quite struggling, and her respiratory rate was about 30, even though she was actually able to talk to me with no problem. And it was only after we'd finished the chatting to each other online that she found her oxygen sats were 88. And I couldn't believe how unwell she was, because she didn't look that unwell, and she was able to discuss a project we were doing.
Yeah, and can I come back there? I think it's really important. If the person looks unwell and you have a clinical feeling that this patient is really very sick, they almost certainly are very sick. If, on the other hand, the patient doesn't look very sick or doesn't sound very sick, you may be right, but you may be wrong. And what we're looking at now, we've got a cohort of patients with what we call long COVID, which is not the topic of today's seminar, but as you all know, that this is a problem. We think sometimes that long COVID had its origins in the patient had an acute episode. They were reassured because they didn't sound very sick, and so they stayed at home. They didn't get the oxygen they needed, and now they've got a kind of drawn out illness. It's not always the case that the patient had early hypoxia, but again, we've got another research study going using data linkage to see whether that early hypoxia predicts the development of long COVID. That's probably enough on that from me.
That's very interesting, particularly since we weren't actually admitting many patients, and we didn't know about low oxygen sats at the beginning of the lockdown last year. But Kamlesh, I think I saw you put your hand up. I have got a question, but did you have something else to add on video consultation?
I didn't share the consultations we've done. Alison, you're a general practitioner, and routine consultations we do about 30, 40 in the morning, and the problem is that there are inequalities in access to video consultations. As you know, the elderly can't get to them, the deprived populations who can't get to them, there are language issues, and they're the ones who are missing out. But phone call does really, really well. It's quicker as well. Video consultation is quite finicky, it doesn't always connect. So we tend to do most of them. And it's when we need to observe, as Tricia said, it's only then that you need to do the video consultation.
Thank you. Thanks for adding that. And it also fits with what Prabhakar was saying about the kind of inequalities. Smartphones are Jadi. Thank you.
Can I just come in on this, Professor Greenhalgh? What the protocol followed in the state actually looks at, we get people to walk 40 steps. And if the O2 sats fall by about 3%, we think that they are better off on steroids. One other indication for giving steroids is if the oxygen saturation drops by more than 3% on doing 40 steps. Yeah. That's the protocol we've been following here.
Fantastic, because that's also the protocol we've got in the recap score. And just to reiterate, I think people have said this before, but it's so important that it is only the case that steroids improve outcome if the patient is hypoxic. But obviously, if they've done the 40 steps on the flat test and failed that, then they are hypoxic. So as you say, the likelihood is they will improve on steroids. But we know from randomized controlled trials, if the patient is not hypoxic, if the patient is not particularly sick, the steroids will not improve outcome, and they risk a poor outcome because even if they're not diabetic, if you put them on steroids, as you know, you may precipitate diabetes or impaired glycemic control. And someone described it as the Hail Mary approach, which metaphor may not transmit. I think it was an Irish person that said that, but the idea is you throw everything at the patient because they've got COVID. So you throw a steroid, you throw the antibiotics, you throw all sorts of drugs because you think you want to help them, but actually that doesn't help them. They'd be better off self-managing paracetamol, fluids, all that kind of thing. But if they're hypoxic, then in general, steroids will help.
Thank you. Oh.
I'll just, to what Professor Greenhalgh actually talked about, here what we do is when we tell the bystanders or relatives to look at to get a count of the respiratory rate, rather than looking at the chest, we ask them to observe the abdomen, the rise and fall of the abdomen. Most people actually find that more easy rather than looking at the chest.
That's very interesting. And
interesting, yeah.
And I think also it's something that with some of the work as a COVID lead we've been looking at is actually trying to get in and make sure the families know what to look for. Because if people have got low oxygen saturations, they often they're not thinking straight.
This raises a wider issue, which my team are doing quite a lot of research into, which is the remote clinical examination, where, you know, when I was at medical school, they taught me to examine a patient. They didn't teach me to teach the patient to examine themselves with or without technologies. But now I've done a lot of observing, particularly nurses working through video, explaining things to patients. How do you take your blood pressure? How do you take someone else's blood pressure when you're not trained? And when the doctor or nurse is in a different building. And these are things we need to teach our students. You know, when the pandemic's over, we need to gain this wider skill set of how do you instruct a relative to take a clinical observation. And this is wide open for more research. But I'm thinking this tip about watching the abdomen is just the kind of thing we need to do more work on.
Thank you. And I can see that Prabhakar's also got his hand up. So what tips are we going to learn from you to take?
No, I just was going to draw the panel's attention as well as the attendees who are listening here. I'm kind of flabbergasted at the prescriptions I've seen. So anybody who is diagnosed to have COVID gets the cocktail of all these: favipiravir, doxycycline, azithromycin, ivermectin, budesonide inhaler 800 microgram twice a day, vitamin C twice a day, Zincovit, and there may be several others. So I think we'll have to be very, very careful. Like I think we're just going overboard Now, ivermectin is there in most of the important hospitals. I mean, the big hospitals in India, in their protocol, it's there. It's a drug. I mean, the worst it can do is it can rid you of all the parasites in your body. I mean, beyond that, I don't think it does anything. But I'm worried about things like favipiravir, which have side effects. Even doxy and azithromycin, it can just lead to resistance unnecessarily, and they have side effects. Vitamin C and Zincovit may maybe make your urine costly. Other than that, they don't do anything. So one need to be more rational in the prescription, at least in the mild cases. Second thing is about steroids. The recommended dose is dexamethasone 6 milligrams daily. But I've seen prescriptions where people get methylprednisolone 60 milligrams twice a day. I think that's going over now. So, although people say that they have had good clinical experience, but these are all anecdotal and observational. Clinical trial that are shown is dexamethasone 6 milligrams and equivalent amount of prednisone, which could 60 milligrams twice a day.
Thank you.
I don't know what others think here.
Thanks for raising that, for explaining a bit about the high dose steroids, because I know there's a lot of concern. We want to try and end on time, so I had got more questions, and one of them had been whether COVID could be passed to pets, and certainly in the chat, I think Kamlesh said that it could be passed to pets. I've got lots more questions. I'm really sorry that we haven't got time to ask them all. So I'm now going to hand it back to Rachna. So thank you very much, the panel, for answering all those questions and contributing much more than just a simple answer. Thank you, Rachna.
Thank you very much, Alison, and thank you, Prabhakar, Trish, Jaydeep and Kamlesh for such a rich exchange. And thank you to all of you for the questions that you have posed. If people are up for a quick 20-second, 1 minute or 20-second takeaway from the panelists, if something comes to mind, then you're welcome to unmute and say something, as we're doing all right for time. Any last minute messages from anyone? We might have covered them all. Alison, you did such a great job. I think we did. Okay, well, fantastic. Look, thank you everyone for tuning in today. Thank you to everyone who's here attending. Thank you to our panelists. Thank you to Alison for facilitating. And of course, thank you to the people in the background who do all of the magic. The slides, the certificates, the recording and other resources will be available to everyone on the website of the South Asian Health Foundation. And the next webinar on Tuesday, same time, same place, will be on mental well-being and COVID. And I think we should pat ourselves on the back for giving everyone 2 minutes somehow. That's very rare. Well done, everyone. Thank you.
Thanks very much.
Thank you all. Thanks, Prabhakar.
Thank you.
Thanks. Bye, Trish.
Are we going to make the beginning?